There are some populations at greater risk for health issues than others, and disparities for these populations is increasing. In order to care for and marginalize these vulnerable groups, the DMP nurse leader needs to think strategically for new approaches. A population-based intervention plan for worksite smoking cessation. Researched, designed, and presented by Amy Thornberry, Texas A&M University, Corpus Christi, College of Nursing and Health Sciences. The focus, target population, is production workers in a rural South Texas manufacturing facility, using the precede-proceed model. As smoking continues at a much higher prevalence than expected, global and local statistics for smoking subpopulations are reported and compared within the working American population. This study explores strategies for a real-life intervention plan in South Texas where subpopulation disparity exists. A proven smoking cessation model guides the assessment, planning, and intervention process and provides ongoing evaluation for a cessation program. Finally, opportunities for banning smoking through tobacco control policies and implementing effective worksite programs for smoking cessation have not been realized. I use a multidimensional approach as a guide to research methods of organizational change and individualized strategies to control and reduce the smoking disparity that exists among the identified group. The smoking disparity continues as an unresolved problem. The World Health Organization identifies smoking as the most prevalent leading cause of death for all populations in the world. Globally, smoking prevalence extends to over 1 billion people. But even more compelling are the worldwide accounts of tobacco use, killing approximately 5 million people annually. As death rates for non-communicable diseases have declined, the proportion of adult deaths due to smoking will rise. In the 21st century, smoking is predicted to kill 175 million people between now and the year 2030. Smoking has been the most influenceable health determinant of the past several generations. Today, tobacco is expected to kill about 1 billion people. The total approximate cost for tobacco-related disease will be more than $13 trillion over the next few decades. Two social determinants have the greatest impact of smoking disparity. The greatest social impact involves the less educated and lower income. As seen in this table, education levels for adult smoking rates with a GED is 34% compared to those with higher graduate degrees at 3.6%. The subpopulation with more education reports a lesser prevalence of smoking, and conversely, low education is associated with reports of the highest levels of smoking. Income status is another quantitative factor for smoking prevalence in the U.S. Financial status below poverty level is correlated with twice the prevalence for smoking. Comparatively, smoking among persons living at lower incomes are significantly greater at risk for smoking. In the U.S., the smoking dilemma continues as an insidious causation to chronic disease, as reports of tobacco use account for 33% of cardiovascular disease, 50% of cancers, and 60% of chronic respiratory disease. Additionally, COPD is associated with males, lower education, smoking, underweight or obesity, and occupational dust and fumes, all leading to the epidemiological approach for a target population. I will apply the population health precede-proceed model for this study. The assumptions of this model are as a guide for the practitioner with a framework translating research insights into a systematic approach. The premise is a structured model will improve population health outcomes and quality of life through a structured plan grounded in organizational and educational approaches. The design incorporates multiple theories as social cognitive, individual, interpersonal, community, and organizational change. The model will assist during the planning process by asking questions and during the developmental stages for decision making. For instance, predisposing cultural and social barriers can be identified through interviews and surveys to try to understand the working community and their perceived needs. For instance, impact of family, peers, work colleagues, shift work, accessibility to cessation programs, and health insurance benefits are all part of determining the reinforcing attributes for smoking behaviors, which can be identified through assessment and data collection. The Precede-Proceed model outlines a planning process. Precede is a helpful mnemonic that asks questions during the developmental stages. It utilizes 9 total phases, including steps for decision making, and it's a multi-dimensional approach for assessing health behaviors and environments to design, implement, and evaluate health promotion. Once identified, steps for determining reinforcing attributes through epidemiological assessment and secondary behaviors, for instance, where the community may have a greater smoking rate in rural populations compared to urban settings. During the implementation phases, the model will assist with steps to proceed with methods for assessment and planning. The implementation phase for this model includes process evaluations, including impact of outcomes like monitoring smoking cessation rates for sustained abstinence, and finally, Precede-Proceed models have proven to be successful. Examples are for developing smoking cessation programs in Canadians, and also for helping with health services interventions in Australia. Smoking cessation in and of itself is a primary preventative measure for many premature deaths. Quitting is considered a mainstay for health promotion. For this intervention plan, smoking cessation will be treated as a disease entity. So, primary prevention measures would restrict or eliminate cigarettes from human consumption. Organizational change will focus on smoking cessation and restricting smoking in the workplace. Some strategies for incentive programs for smoking cessation have been used, but these are inconclusive. Other strategies include policy enforcement for the prohibition of smoking. The Community Task Force shows strong evidence based on the results from 82 studies that smoke-free policies reduce smoking prevalence. The World Health Organization includes tobacco policy as an essential element for control. The mnemonic Empower directs action for tobacco control. Strategies are as follows. M. Monitor tobacco use and prevention. P. Protect people from tobacco. O. Offer help to quit. W. Warn about the dangers. E. Enforce bans on tobacco and advertising. R. Raise taxes on tobacco. A secondary intervention strategy is aimed at effective smoking cessation programs. As DMP nurse leaders, we must offer help to quit. Opportunities for intervention are often missed in the clinical setting with focus on treating illness rather than preventing it. Of interventions often missed, approximately 70%. Also, 70% of smokers who try to quit do not use evidence-based clinical cessation protocols. The 5 major steps for smoking cessation, the 5 A's, ask, advise, assess, assist, and arrange for follow-up. Implementing a clinically based protocol guideline for smoking cessation can manifest in substantial positive gains for smoking cessation programs. The surveillance plan will include a systematic collection of biostatistical information about adult smoking population ages 18 through 45. Comparative data will be acquired through online national and local databases and on population-specific subcategories as smoking trends for age, sex, and occupation. These include county health rankings and roadmaps for 2017, the CDC and the Bureau of Labor Statistics, and internal health records for workers at a South Texas manufacturing facility. A personal survey tool will be designed to determine smoking behaviors. and for individual and behavioral usage trends and personal triggers for smoking. Social and organizational factors would be identified through interviews and meetings, for instance, smoking restrictions in the workplace. Implementation will include presentations to stakeholders as organizational leadership, explaining the rate of smoking and proposed plan. Management will be involved with the environmental factors and organizational responsibilities in complying with laws. This may involve planning meetings with leadership for exploring cultural and organization determinants. A change in smoking restriction policies may be needed. Individual data collection and health surveillance for smoking will be provided during the annual required employee health exam. Smokers identified as current or ever smoked will be asked to complete a health surveillance. Implementation will begin as the DNP advises smokers to quit and assistance for smoking cessation is provided. Evidence exists that brief cessation interventions by health professionals are effective. Evaluation of the intervention plan determines whether the goals have been achieved and the population has benefited. In determining efficacy of the plan, is the population with greater disparity most affected? The population with the quantifiable smoking trend are the lower income, less educated male worker. Comparative data shows rural South Texas is at increased risk compared to national and state averages. Effectiveness of the intervention is evaluated when the workers are subject to testing. Do the workers complete survey requirements and begin cessation programs to indicate effectiveness? This occurs as they complete required respiratory health exams and begin the implementation process. Finally, the cost-benefit ratio will determine if the implementation strategies are efficient. As evidence is measured and collected, the DNP will provide program summaries and report outcomes, identifying gaps and next steps for sustained progress. Translating findings. There is strong evidence for policy and regulation on smoking bans which impact smoking cessation. As DNP nurse epidemiologist, becoming involved with policy restriction for smoking is a key role, but use of evidence-based techniques are not fully utilized. As we discover evidence-based smoking cessation techniques for improved cessation rates and apply these with models for success, our goal for a smoke-free environment may become a reality. Applied models for successful programs have not been fully utilized. Because leadership is an attribute of the DNP, we must use evidence-based data and statistical trends to educate stakeholders and the population at risk. By using translational science and real-life situations, we have a process to combat the disparity of chronic disease from smoking, and we can benefit the health of our population.